In the name of the most merciful Allah, Salam everyone, I hope you are doing great. Today we are going to talk about tubular processing of substances after they are filtered into the renal tubules. After filtration of plasma from the filtration barrier at the level of glomerular capillary, many different substances with different concentration will also be filtered into the Bowman's capsule and renal tubules. What happens after filtration? For a given substance, for example substance X, the amount that is filtered can be calculated by multiplying GFR in milliliter per minute by plasma concentration of that substance, that is, for example, for electrolyte, milliequivalent per liter. And the final unit will be milliequivalent per minute, the amount of substance that every minute is filtered from the filtration barrier, through the filtration barrier into the Bowman's space. For the given substance, it may undergo reabsorption after filtration. So for other substances, they may undergo secretion into the renal tubules from peritubular capillaries. And what is remained in the renal tubule finally will determine the amount excreted in the urine. We can calculate excretion rate of substance X by multiplying urinary flow rate by urine concentration of that substance, and again the unit is similar to the amount that is filtered in milliequivalent per minute. The amount of reabsorption or secretion determines the final excretion rate of a given substance. For many substances, they are mainly reabsorbed, so the amount that is excreted will be smaller than the amount filtered. For some waste materials, the amount that is excreted is normally more than the amount that is filtered, and the excretion rate will be higher than filtration rate. In other words, the secretion rate will be added to filtration rate and the excretion rate will be determined. For example, for substances that their filtration rate is higher than excretion rate and net reabsorption occur for them are water, nutrient, and most electrolytes. And for finding reabsorption rate, we can subtract excretion rate from filtration rate, or the difference between filtration rate and excretion rate is the reabsorption rate for that substance. For some other waste materials that excretion rate exceed filtration rate, it shows that net secretion occurs from peritubular capillary into the renal tubules. Most waste materials and also a little for creatinine, there's some level of secretion. To calculate secretion rate, we can find the difference between excretion rate and again filtration rate. There's few substances that the filtration rate and excretion rate equals, and neither secretion nor reabsorption occur at the level of renal tubules. Inulin is for example, a known substance that after filtration will not be reabsorbed or secreted, and the amount that is filtered will be equal with the amount that is excreted. So the difference between filtration and excretion rate will be 0 for them. Sometimes creatinine also is considered with this property and is considered similar to inulin. We will talk about it in the succeeding topic, that inulin or creatinine are used to calculate GFR for an individual, for a subject or patient. Let's look at some example calculation. For sodium, the amount that is filtered can be calculated by multiplying GFR, that is normally 125 milliliter per minute, by its plasma concentration in milliequivalent per milliliter, that is 0.142, and the result is 17.75 milliequivalent per minute. This is the filtration rate for sodium per minute. What is the excretion rate? The normal urine flow rate in every minute is about 1 milliliter. So urine flow rate is 1 milliliter per minute multiplied by urine concentration of sodium is about 0.13 milliequivalent per milliliter. Normally they are expressed in milliequivalent per liter, but because we want to find a final unit for them, both of them should be expressed in milliliter, both urine flow rate and urine concentration. And in this way we can reach a final unit, that is milliequivalent per minute, and it is 0.13 milliequivalent of sodium per minute that is excreted from the body. So you see that the amount of filtration is much higher compared to the amount that is excreted, and the net reabsorption rate is about 17.62 milliequivalent per minute. For potassium, the GFR is the same, 125. Plasma concentration for potassium is 4 milliequivalent per liter, but if we convert it to milliequivalent per milliliter, we should divide it with 1000, and it is 0.004, the plasma concentration of potassium, and it is equal 0.5 milliequivalent per minute. The excretion rate for potassium is calculated in this manner. Urine flow rate is 1 milliliter per minute. That if we calculate it for 1 day or 24 hours, it will be 1.5, about 1.5 liter per day, and it is 1 milliliter per minute. From both kidneys, this volume of urine is generated. Multiplied by the urine concentration of potassium, it is about 0.012 milliequivalent per milliliter. It is 4 times more concentrated compared to 3 times more concentrated compared to plasma concentration, but the final excretion rate will be 0.012 milliequivalent per minute, because the urine flow rate is smaller compared to filtration rate. Again, the filtration rate is more than excretion rate, and the net reabsorption rate will be 0.488. For urea, its plasma concentration is expressed in milliequivalent per deciliter. It is about 14 milligram per deciliter. Sorry, milligram per deciliter. But if we convert it to a milligram per milliliter, we should divide it by 100, and it is 0.14. Multiplying by GFR, it is 17.5 milligram per minute. This is the amount of urea that is filtered from filtration barrier into the Bowman's capsule every minute. 17.5 milligram. Let's calculate excretion rate of urea. 1 milliliter per minute urine flow rate and 14 milligram per milliliter. You see, this is concentrated in urine about 100 times. So it is 100 times 100 times concentrated in the urine, and the excretion rate is 14 milligram per minute. Again, even though it is much higher concentrated in the urine, but comparing with filtration rate, excretion rate again is smaller compared to filtration rate for urea, and again net reabsorption for urea will be 3.5 milligram per minute. But for creatinine, finding the filtration rate is about, plasma concentration is 0.01 milligram per milliliter or 1 milligram per deciliter. But we have converted it to milligram per milliliter to be easily considered with milliliter per minute. We express GFR in it. So it is 1.25 milligram per minute, the filtration rate of creatinine. And the excretion rate of creatinine, it is urine concentration is 2 milligram per milliliter or 200 milligram per deciliter. We have converted it to milligram per milliliter. It is 2. And the final excretion rate for creatinine is 2 milligram per minute. This is the amount of creatinine that is eliminated from the body every minute. So comparing excretion rate and filtration rate, we see that excretion rate for creatinine is higher than filtration rate. It shows that there has been some secretion that have been added to filtration. So the net secretion rate will be the difference between excretion rate and filtration rate, and it is 0.75 milligram per minute. These are some examples how we calculate filtration rate, excretion rate, reabsorption rate, or secretion rate. Also, it is important to consider the units of GFR or UFR, concentration and rate of filtration, reabsorption, secretion, or excretion. GFR or UFR are expressed in milliliter per minute, volume per time, or liter per day. Concentration is the amount per volume or milliequivalent per liter or milligram per deciliter. For many substances these are used, and some other units, for example millimole per liter. And for rate of filtration, reabsorption, secretion, or excretion, normally amount per time is used. Milliequivalent per day or milligram per day or milliequivalent per minute, milligram per minute. You should consider these units. After filtration of plasma, glomerular filtrate is modified by epithelial transport as it flows along the nephrons tubules. For water and many solutes, including nutrients and electrolyte, 98 to 99% or more is reabsorbed back into the pertubular capillaries. This reabsorption for water and many solutes is highest in the proximal convoluted tubule, about 70% or more, even for potassium. An excretion rate for any substance is determined by tubular reabsorption rate for that substance. And fine control of excretion mainly occurs in the distal portion of nephron, including distal tubule, late part of distal tubule, collecting tubule, and collecting duct. Somehow a constant fraction of filtrate reach to the distal portion of nephron. About 10% of glomerular filtrate reach to distal portion of nephron, and over there it is determined how much is reabsorbed for a given substance and how much remain inside the tubule. For waste substances such as potassium, hydrogen ion, and organic anions and cations, including most drugs, excretion rate is mainly determined by tubular secretion rate for them through the tubules of the nephron. In this table, you see the filtration rate and excretion rate, and also reabsorption rate for different substances, and also the percent of filtered load that is reabsorbed. As you know, for nutrients, percent of filtered load that is reabsorbed is 100%. It means that all of them are reabsorbed. The amount filtered is, for example, for glucose, it is 180 grams per day, but excretion rate is 0. For bicarbonate, it is near 100%, but just a little amount of bicarbonate is excreted. So it is more than 99.9% of bicarbonate that is reabsorbed of filtered load. For sodium and chloride, it is more than 99% of filtered load. You can find it by subtracting excretion rate from filtration rate. It shows the amount that is reabsorbed, more than 99%. For potassium, the amount that is filtered is somehow lower compared to sodium or chloride, because the level of potassium in plasma is much lower. But again, about 88% of filtered potassium into the renal tubules will be reabsorbed, and just about 12% will be excreted in the urine. We can calculate it by considering excretion rate and filtration rate. For urea, about 50% of filtered urea will be reabsorbed normally at a normal level. And for creatinine, the amount reabsorbed is 0, and even there's a little secretion, so the amount excreted is somehow considered equal with amount filtered. It is a little higher compared to filtered load of creatinine, as we have talked about it. And overall, this shows that the tubular reabsorption is quantitatively large and highly selective. It is nutrient. The renal tubule decide that if it is nutrient, all of them should be reabsorbed. If it is bicarbonate, near all of it should be reabsorbed. If it is sodium or chloride, more than 99% should be reabsorbed. If it is potassium, about 88% should be reabsorbed, and for other substances in this way. So it shows that it is selective, that which substance is undergoing transportation, and the renal tube decide that how much reabsorption should occur for that substance. The tubular transport includes two main mechanisms: overall reabsorption or secretion. For these two processes, the mechanism can be active or passive. And the third mechanism is bulk flow by the way of stalling forces. It is somehow similar to filtration of fluid. In the same way, reabsorption of fluid into the peritubular capillary can occur. It means that water and many other solutes are reabsorbed or secreted, mainly reabsorbed by bulk flow. The active and passive mechanism are mediated by transporters, and as you know, the transporters can be saturated, so there's a value for each transport mechanism known as transport maximum, the maximal amount that can be reabsorbed or secreted. In other words, the maximal transportation rate. Tubular reabsorption occurs from tubular lumen to peritubular capillary from two pathways: paracellular pathway and transcellular pathway. In this figure, you see how renal tubules are closely related with peritubular capillaries. There's a basement membrane between peritubular capillaries and renal tubular cells that facilitate easy reabsorption or even secretion from this space to this space, from luminal space to interstitial fluid, and from there to peritubular capillaries. Tubular cells have two main sides: the luminal or apical side or apical membrane, and basolateral side, include basolateral membrane. That these two sides are separated by tight junction that connect the adjacent cells together. Active mechanism includes primary and secondary mechanism. For example, primary mechanism including activity of sodium potassium pump in the basolateral membrane directly by consumption of ATP transport substances in their against their concentration gradient, and also the secondary active transportation that, for example, use the inclination of sodium, a high concentration of sodium that want to enter to the cell, and this carries another substance with it. The passive mechanism includes diffusion, simple diffusion or facilitated diffusion. Simple diffusion occurs for some substances and also for water, that is known as osmosis. And also bulk flow, that is opposite of filtration. All of them occurs here. Glomerular filtrate that pass along the renal tubules undergo this reabsorptive mechanism, transportation, by the paracellular pathway or transcellular pathway, and from the interstitial space around the renal tubules by the way of bulk flow into the vertebral capillaries. And what is remained inside the renal tubule will be excreted. For the bulk flow, stalling forces determines, and stalling forces inside vertebral capillary and outside vertebral capillary in the interstitial fluid. If you consider the values, you see that hydrostatic pressure is much more smaller compared to the hydrostatic pressure at the glomerular capillary level, but the oncotic pressure inside vertebral capillary is much higher. And also for the hydrostatic pressure in the interstitial fluid, it is 6 millimeter of mercury, and oncotic pressure is 15 in the interstitial space. The net reabsorption pressure is 10 millimeter of mercury, favoring reabsorption. As you remember, at the level of glomerular capillary, it was plus 10 millimeter of mercury favoring filtration, but here, due to lower hydrostatic and higher oncotic, 10 millimeter of mercury favors reabsorption into the vertebral capillary around the renal tubules. The most important driving force for reabsorption is due to activity of sodium potassium pump, and without the activity of this pump, the reabsorption rate will diminish to severe level. The transporter along the nephron can be saturated when they encounter higher concentration of solutes. For example, considering glucose levels in the plasma, normally it is less than 100 milligram per deciliter, and the filtered load for glucose is about 125 milligram per minute. By finding it by using this formula, we have talked about it previously, filtration rate. When the plasma concentration of glucose goes higher than 125 milligram per deciliter, it is considered as hyperglycemia, higher glucose level in the blood. The threshold for glucose to appear in urine is when the plasma glucose levels reach to more than 200 milligram per deciliter. But the capacity of nephrons to transport glucose is the highest level of transportation, or the maximum transport is 375 milligram per minute. So when the filtered load of glucose is increased due to, for example, increased glucose level in the plasma or due to increased GFR, glucose may appear in urine. In this curves in this graph, you see how by increasing plasma glucose concentration in the x-axis as it is shown, how the filtration rate, reabsorption rate, and excretion rate of glucose is changing. For example, at the normal level, the filtration and reabsorption equals. All filtered glucose will be reabsorbed. But by increasing the concentration, and when the concentration of plasma glucose reaches to 200 levels and more, the reabsorption rate and filtration rate will be separated because the reabsorption reaches to its saturation in some nephrons. So you see that after this concentration, the reabsorption rate is less than filtration rate. By increasing concentration of plasma glucose, the excretion rate of glucose will increase, and after a given concentration, for example 375 milligram per minute, the plateau will be reached because it is the highest capacity of transporter that they can transport glucose per minute. After this concentration, by increasing the concentration of plasma glucose, all this extra glucose will appear in the urine. So reabsorption will remain fixed, and any extra glucose that is filtered will be excreted. Between threshold and plateau concentration, you see that there's a phase. It is known as supply phase. It is due to that not all nephrons have the same transport maximum for glucose. Some of them has higher capacity, some of them has lower capacity, but when all nephrons has reached their highest capacity and saturated completely with glucose, the plateau is reached. But some nephrons will be saturated in a smaller concentration, in lower concentration, and because of that, the threshold is lower than the transport maximum concentration. It is true with secretion. When the concentration of the solute that is supposed to be secreted, for example, PAH or para-aminohippuric acid, you see that by increasing the concentration of PAH in plasma, the filtered load of PAH will increase in a rectilinear manner. For any given concentration of PAH in plasma, you see that the excretion rate is much higher than filtered load. It is because of the secretion of PAH that is added to the filtered load. And you see that the secretion rate is much higher compared to filtered load. But again, it can be saturated. For example, when the concentration of PAH reaches to 20 milligram per deciliter, at that time the PAH transporter will be saturated, and from that concentration beyond, by increasing the concentration, you see that the excretion rate will increase in a rectilinear manner as the filtered load is increasing, because the secretion has saturated and just the amount that is filtered will be added to the amount that is secreted, and it remains somehow in a rectilinear manner to the and you see that comparing the excretion rate before and after saturation, before saturation it is more steep, but after saturation it gets less steep. It is because of the transport maximum of PAH that is reached in a given concentration of PAH. In this table you see transport maximum for substances that are actively reabsorbed by the tubules, for example glucose, phosphate, sulfate, amino acids, urate, lactate, plasma proteins, and also for substances that are actively secreted by the tubules, such as creatinine and PAH. These are non-waste substances. Some actively transported substances don't reach the saturation level and they are known as substances without transport maximum. Let's consider the factors that determines the level of transportation: gradient, time, and permeability. As the electrochemical gradient between two sides of the two space and across a barrier is increased, it will increase the amount of transportation through that membrane. The second is the permeability of membrane. As the permeability is increased, the level of transportation will increase, and also the time of contact with tubule, or the flow rate of the tubular fluid. As the flow rate of tubular fluid is decreased, the time of contact with tubule will increase. So, by having these three factors, the transportation level will be determined. Considering this, some substances, for example sodium, don't saturate due to higher permeability of tight junction in the early proximal convoluted tubule, and back leak occurs from the interstitial fluid into the luminal space, and this back leak prevents saturation of sodium reabsorption. It occurs in early PCT, not late. In the late PCT, the tight junctions are much more tight, but in the early PCT they are leaky. Also, stalling forces in the interstitial fluid that, for example, sodium load, when sodium load is increased due to hypernatremia or due to reduced flow rate and increased time of contact with tubule, the sodium reabsorption rate will increase, and this will increase the electrochemical gradient of sodium, and it will favor again back leak from interstitial fluid into the luminal space. Again, it will prevent saturation. And also, the Tm for sodium can be changed, can be increased by aldosterone in the distal tubule, because more sodium transporters will be inserted into the membrane and will increase the capacity for transportation of sodium. This mechanism can change the transport maximum level of sodium. In the early PCT or proximal convoluted tubule, the tight junctions are leaky and they are highly permeable to water and moderately permeable to most ions. Let's talk about reabsorption and secretion along the nephron in more detail. You are familiar with different parts of nephron, starting from renal corpuscle, including glomerular capillaries and Bowman's capsule. Connected with it is PCT or proximal convoluted tubule. The late part of proximal tubule, known as straight part, is the thick descending limb. After that, the intermediate tubules, including thin descending limb of the loop of Henle and thin ascending limb of the loop of Henle. After that, the thick ascending limb of the loop of Henle, sometimes it is known as straight part of the distal tubule, and then the convoluted distal convoluted tubule, connected with collecting tubule, and finally collecting duct. There is a specialization of cells along the nephron in each part of nephron. For example, in the PCT proximal tubule, you see that the cells are thicker with extensive brush border to increase the reabsorption surface area. And for the thin part of the loop of Henle, the cells are thinner. You see, in other part, the cells again are specialized, and also maculodense cells, more specialized cells in the juxtaglomerular apparatus. And in each part, you see specific types of cells that each perform its given role in processing of filtered fluid. You see a micrograph of luminal cells, the extensive brush border in PCT cells, and increase the reabsorption surface area about 20 times more than a simple surface compared to a simple surface. In the proximal tubule, as we mentioned, about 65 to 70% of filtered load will be reabsorbed. For sodium chloride, bicarbonate, potassium, water, glucose, amino acid, more or less percentage than 70% will be reabsorbed, and also some secretion of waste substances such as hydrogen ion, organic cations and anions, or organic acids and bases are secreted in this part. Let's look at mechanism involved in early proximal tubule and late proximal tubule in reabsorption or secretion of different substances. In the proximal tubule, the mechanism involved in sodium reabsorption are in this manner. In the luminal membrane, there are some transporters. Through them, sodium enter into the cell. For example, the symporter of sodium glucose or sodium glucose transporter, and sodium amino acid transporter, sodium phosphate transporter, and sodium hydrogen exchanger. This last one is an antiporter that for one sodium that enter to the cell, one hydrogen ion will be secreted into the luminal fluid. In the basolateral membrane for sodium, the main reabsorption mechanism is activity of sodium-potassium pump, and actively will pump sodium out of the cell. Also, there's a symporter known as sodium bicarbonate cotransporter that carries one sodium with 3 bicarbonate molecule. It is a pathway that reabsorbs bicarbonate. For glucose and amino acids or nutrients in the luminal membrane, as we have talked about it, the transporters that co-transport nutrient with sodium are type of secondary active transport in a luminal membrane, but in the basolateral membrane it is a type of facilitated diffusion, because when nutrients enter to the cell, their concentration inside the cell increase, and by using a transporter they can go out of the cell and into the interstitial fluid. But for transporters in the initial segment of proximal tubule and the last or third segment of proximal tubule, the transporters differs. For example, 90% of glucose transportation occurs in the luminal membrane by the way of sodium glucose transporter type 2 in the luminal membrane, and in a basolateral membrane by way of GLUT type 2. The remaining 10% of glucose will be reabsorbed in the last portion of proximal tubule or the third segment by the way of type 1 of these transporters, SGLT1 and GLUT1. And for the hydrogen ion, we have talked about it. It is a type of secondary active transportation, but it is a type of exchanger or countertransportation, and secrete proton or hydrogen ion into the lumen. Let's see how reabsorption of water and other solute is dependent on sodium reabsorption in proximal tubule. After active reabsorption of sodium and its accumulation in the interstitial fluid, the osmolarity of interstitial fluid will be increased, but in the luminal space and luminal fluid, the osmolarity will decrease. So the water favors to go on to other side of the luminal cells by the way of osmosis, transcellularly by the way of water channels known as aquaporins. For example, AQP type 1 is a type of channel that provide a transcellular pathway for water to be go out other side of the luminal cells into the interstitial space, and also by the way of tight junction in a paracellular pathway in the early PCT that is leaky by a solvent drag. Water with many solutes in it favors to go to other side of the luminal cells. So after sodium reabsorption and change in osmolarity in two sides of the luminal cells, water goes to other side by osmosis. When water and sodium are transported in this way, the concentration of other solutes inside the lumen will increase. For example, the concentration of chloride will increase, urea will be concentrated, and other solutes. By increasing their concentration in the luminal space, luminal fluid, they want to diffuse to other side because the concentration gradient favors diffusion of the substance from luminal space to interstitial fluid. But because the proximal tubule is somehow impermeable to creatinine, the creatinine cannot be reabsorbed in this way, but chloride and urea will be reabsorbed due to concentration gradient across the luminal tubular cells. The third mechanism for reabsorption of chloride, the third mechanism is for reabsorption of chloride in a way that after reabsorption of sodium and water, because the luminal potential gets negative because positively charged sodium has gone to other side of the luminal cells, and increasing the concentration of chloride in luminal space favors them to go to other side that is positively charged because the luminal space is negatively charged. So this is another way that helps chloride to be reabsorbed. So as we see, the reabsorption of water, chloride, urea is dependent on sodium reabsorption. So anything that changes the sodium reabsorption will affect the reabsorption of water and most solutes. In this graph, we follow up the tubular concentration of different substances compared to plasma concentration. For nutrients, amino acids, and glucose, you see that through the length of the proximal tubule, that is shown in percentage here, as we go to the end of the proximal tubule, the concentration of tubular fluid for glucose and amino acids is reduced to much lower level, near zero. For bicarbonate also, because most of bicarbonate is reabsorbed to the end of the proximal tubule, its concentration in tubular fluid compared to plasma will be much lower, because it is ratio, it is about 20% of what is present in the plasma when it reached to the fluid reached to the end of the proximal tubule. For sodium and chloride, their concentration in tubular fluid compared to plasma somehow remain the same, and also the osmolarity of the fluid, because the reabsorption along the proximal tubule is a type of isosmotic reabsorption, because after sodium reabsorption, water will be reabsorbed and chloride will be reabsorbed. So it is a type of isosmotical reabsorption. So the osmolarity and concentration of sodium and chloride to the end of the proximal tubule remain similar to plasma. Urea is a little concentrated, but creatinine, because the proximal tubule is impermeable to creatinine, it is concentrated more than threefold. About threefold it is concentrated to the end of the proximal tubule. There are important mechanisms for secretion of organic anions and organic cations in the proximal tubules. In the basolateral membrane, there are organic cation transporter or organic anion transporter, and by this way, this organic anions or cations enter to the cell, and by other mechanism in the luminal membrane, they are secreted into the lumen, and in this way they can be eliminated from the body. Again, the driving force for these secretions come from activity of sodium-potassium pump, and also some exchanger play role in basolateral membrane and also in the luminal membrane to finally secrete these organic cations and anions into the luminal fluid. Some examples of organic anions and cations are presented in this table just for getting familiar with them. For example, many known drugs you can find in these lists. It is rare, but if any protein is filtered into the Bowman's capsule and enter to the proximal tubule, the proteins will be reabsorbed via endocytosis mechanism known as pinocytosis. In the luminal membrane, endocytosis will occur by binding up protein to a given receptors, and from the other side, from the basolateral membrane, they will undergo exocytosis as a form of a degraded protein, that is the final product of it is amino acids, and amino acids will enter into the interstitial fluid. Again, because of the transport maximum due to saturation of these transporters. Sometimes due to some problems such as glomerulonephritis, we have talked about it, albuminuria can occur that exceed the capacity of these transporters to bind to albumin and reabsorb it in the form of amino acids. So the albumin will appear in the urine when the rate of filtration of albumin due to some kidney injuries is increased. The next part of the nephron after proximal convoluted tubule is the seen descending limb of the loop of Henle. This part is permeable only to water. In the seen descending limb of the loop of Henle, in the luminal membrane, AQP type 1 of aquaporin or water channels are found, but in the basolateral membrane, other than sodium-potassium pump, AQP types 3 and 4 are found. For the seen ascending limb of the loop of Henle, these cells are impermeable to water and also other solutes. But in the basolateral membrane, they have active sodium-potassium pumps. A point is important to mention here that AQP type 1 and AQP types 3 and 4 are not ADH dependent and always present in the luminal or basolateral membrane, and because of that, this part of loop of Henle is always permeable to water. The thick ascending limb of the loop of Henle is very active in reabsorption of sodium chloride together with potassium, calcium, bicarbonate, and magnesium. This part is so important. One of the active type of transporters is sodium-potassium chloride cotransporter in the luminal membrane. This part also is impermeable to water and is known as diluting segment because solutes are reabsorbed but water remain inside the tubule, so the tubular fluid will be diluted in this part. Also, part of hydrogen ion secretion occurs in this part. In the thick ascending limb of the loop of Henle, in the luminal membrane of tubular cells, the sodium-potassium chloride symporter or cotransporter is important transporter of these ions. Also, a type of potassium channel known as ROMK stands for renal outer medullary potassium channel, is important for back outflow of potassium back into the lumen, making the charge of the lumen more positive, and this positive charge is important in paracellular reabsorption of bivalent cations such as calcium and magnesium. So the thick ascending limb is important in reabsorption of calcium and magnesium due to this mechanism, due to this recycling of potassium enter to the cell by this symporter and go out of the cell into the lumen by the way of ROMK potassium channels and make it positively charged, make inside the lumen positively charged and help the paracellular reabsorption of bivalent cations through paracellular pathway. In the basolateral membrane, other than sodium-potassium pump, a type of chloride channel and also potassium chloride symporter is present. In early distal tubule, sodium chloride symphote play a role in reabsorption of sodium chloride, and calcium and magnesium is reabsorbed in this part in early distal tubule. This area is a target for PTH or parathyroid hormone and vitamin D3 or calcitriol to increase reabsorption of calcium from this part. In the early distal tubule, the mechanism for reabsorption of calcium is in this way, that there is a calcium channel in the luminal membrane and a sodium calcium exchanger in the basolateral membrane, and in this way help to reabsorb calcium. Late distal tubule and cortical collecting tubule is important in secretion of potassium and also secretion of hydrogen ion. Secretion of potassium occurs by principal cells, pair sodium chloride reabsorption with potassium secretion, and also the type A intercalated cells pair secretion of proton with reabsorption of bicarbonate. Also, the principal cells play a role in reabsorption of water by the effect of ADH or antidiuretic hormone. Also, reabsorption of potassium occurs by type A intercalated cells, but the secretion of potassium from principal cells dominate the reabsorption of potassium in type A intercalated cell, or it is higher than reabsorption mainly. In principal cells of late distal tubule and cortical collecting duct tubule cells, in the luminal membrane, the channels are in this way: the ROMK potassium channel, the epithelial sodium channel, and also a type of water channels that are present when ADH level is higher or increased, or they are ADH dependent, and they are present when the ADH influence the principal cells in this part. They are inserted into the luminal membrane and provide a pathway for reabsorption of water. This type of aquaporins or water channels are AQP type 2 that are ADH dependent, but AQP type 3 and 4 are not ADH dependent and always present in the basolateral membrane. In principal cells, luminal membrane, other than ROMK potassium channel, there's another important potassium channel that is known as BK or big potassium channel, that is important in secretion of potassium into the luminal fluid. Type A intercalated cells in late distal tubule and cortical collecting tubule pair the secretion of hydrogen ion with reabsorption of bicarbonate and potassium, as I mentioned earlier, and they are active in acidosis states. And because normally the cellular metabolism all over the body generate extra hydrogen ion and adds acid to body fluids, the activity of type A intercalated cells are normally high and normally secrete proton or hydrogen ion into the body fluid, and in this way the acid is eliminated from the body. But there's another type of intercalated cell known as type B intercalated cells that mainly secrete bicarbonate into the tubular fluid and pair it with reabsorption of hydrogen ion. This secretion of bicarbonate in the luminal membrane is paired with the reabsorption of chloride by an exchanger known as pentrin. During the experience of alkalosis, the activity of this type of cells, type B intercalated cells, is increased. And also these cells pair reabsorption of hydrogen ion with secretion of potassium. And because of increased secretion of potassium for reabsorption of hydrogen ion during alkalosis, high elimination of or harsh secretion and excretion of potassium can lead to hypokalemia. So the patient that experience alkalosis, they are prone to experience hypokalemia too. The similar mechanism is true with patients that experience acidosis. During acidosis, the renal compensation for higher hydrogen ion in the body, the secretion of proton is increased to eliminate extra proton or acid from the body. But as the secretion of hydrogen ion is coupled with or paired with potassium reabsorption, the patient may experience hyperkalemia and or accumulation of potassium in the body fluid. So during the acidosis state, the patient may experience hyperkalemia due to this mechanism. And finally, the last part of the nephron, the medullary collecting duct, play a role in final processing of the tubular fluid, and this processing occurs before the tubular fluid leave the nephron and enter to the minor and major calyces and renal pelvis, and through the ureter enter to the bladder. This part regulates sodium chloride reabsorption and also pair hydrogen ion secretion with bicarbonate reabsorption, regulate water reabsorption in an ADH dependent manner, and also a particular regulation that is specific for this part is the ADH dependent regulation of urea reabsorption at the last part of the nephron. This ADH dependent reabsorption of urea is so important in concentration of urine, because when we experience dehydration and ADH level increase in our body, we are in need of more water reabsorption and more concentrated urine elimination. So ADH, next to increasing water reabsorption, increase urea reabsorption, and urea reabsorption in the medullary part of the kidneys increase the corticomedullary concentration of solutes, and by increasing the solute concentration in the interstitial fluid out of the nephrons in the medullary part, increase the water reabsorption from renal tubules into the interstitial fluid, and from there into the peritubular capillary. So it is so important that ADH regulates urea reabsorption in this medullary part. This is a big picture of different mechanisms in different parts of the nephron that play a role in processing of tubular fluid to the end of the nephron. And here you can follow the concentration of different solutes in tubular fluid and compare it with glomerular filtrate. You see in different parts of nephron how their concentration can change in comparison with glomerular filtrate. You see that the concentration of amino acids and glucose and proteins or overall nutrients reach to about zero level to the end of the proximal tubule, and also for bicarbonate the similar thing is occurred. but not completely reabsorbed, but somehow a little bicarbonate will remain in the renal tubule at the end of the nephron. The waste substances are concentrated to the end of the nephron. PAH, you see creatinine, and you see inulin, and also urea. All of them are concentrated to much higher level. And also you see that potassium is concentrated at the end of the nephron, but the sodium and chloride concentration in the eliminated urine is somehow similar, a little lower, but somehow similar or a little lower compared to glomerular filtrate. Also, we can see that in the loop of Henle, in the seen descending limb, because only water is reabsorbed, you see that the concentration of solutes are increased. For all substances, they are more concentrated. But in the thick ascending limb of the loop of Henle, because of the reabsorption of solutes, they are diluted. The tubular fluid is diluted in this part, and you see that the concentration of solutes is decreased to some level in this part. And at the remaining part, they gradually mainly increase their concentration, except for bicarbonate. Other solutes concentration will increase from the end of the loop of Henle to the end of the nephron. They are more concentrated due to mainly reabsorption of more water, and also secretion of waste substances, especially PAH, to less extent creatinine, and also secretion of potassium, that you see they are more and more concentrated compared to other solutes. And the final point that is important to mention here is about the role of thick ascending limb of the loop of Henle in diluting tubular fluid. The thick ascending limb of the loop of Henle is completely impermeable to water, even in the presence of ADH. So this is known as diluting segment because only solutes are reabsorbed and water remain inside the tubule, and because of that you see that the solutes are somehow diluted in this part. But after this part of the nephron, in the remaining part, depending on the presence or absence of ADH, the concentration of solutes will change. If the ADH is present due to increased reabsorption of water and also secretion of some waste material, they will be concentrated to the end of nephron. But in the absence of ADH, the solute will be diluted more and more to the end of the nephron, and the urine will be diluted urine. And as you see, because the solutes are concentrated to the end of the nephron after the diluting segment, it shows that this graph is depicted in the presence of ADH. And a point about urea concentration in the diluting segment, you see that compared to other solutes that are diluted, urea is concentrated in the diluting segment. What is the reason for this difference? In a diluting segment or the ascending limb of the loop of Henle, due to activity of urea transporter in the presence of ADH, more urea will enter to the ascending limb, and by secretion of urea into this part, its concentration will increase rather than decreasing. It is a point about the increased concentration of urea in diluting segment. Alright everyone, thank you very much for your time, for your patience, for your caring about the subject, and I hope all the best from Almighty Allah for all of you. Goodbye.